Multifetal pregnancies have the increased risk for the following complications: spontaneous abortion, congenital malformations, low birth weight and growth restriction, hypertension, preterm birth, and long-term infant development. Miscarriages are more likely in multifetal gestations. In one study, the spontaneous abortion rate per live birth in multiple pregnancies was 7.3% compared to 0.9% in singleton pregnancies. Monochorionic twins have a significantly greater risk of spontaneous abortion than dichorionic twins, and those achieved through artificial reproductive technologies are at increased risk for abortion compared with those conceived spontaneously. There is increased incidence of congenital malformations in multifetal gestations. The malformation rate in monochorionic twins was almost twice that of dichorionic twins, and this increase has been attributed to the high incidence of structural defects in monozygotic twins. Fetuses in multiple gestations are more likely to be of low birth weight than those in singleton pregnancies due to restricted fetal growth and preterm delivery. The degree of growth restriction increases with fetal number and is more likely to be greater in monozygotic twins than that in dizygotic pairs. In the third trimester, the larger fetal mass leads to accelerated placental maturation and relative placental insufficiency. With monochorionic embryos, the allocation of blastomeres may not be equal. Vascular anastomosis within the placenta may cause unequal distribution of nutrients and oxygen, and discordant structural anomalies due to twinning may affect growth. In dizygotic pregnancies, marked size discordancy usually results from unequal placentation, with one placental site receiving more perfusion than the other. Size differences may also reflect different genetic fetal growth potentials and can also result from fetal malformations, genetic syndromes, infection, or umbilical cord abnormalities like velamentous insertion, marginal insertion, or vasoprevia. Hypertensive disorders related to pregnancy are more likely to develop in multifetal pregnancies. In women with twins diagnosed with concomitant gestational diabetes, there is a twofold increased risk of preeclampsia. There is no specific zygosity that confers a greater rate for developing hypertension, but there is an increased risk for hypertensive disorders in those with triplets and quadruplets when compared with that for twins. Preterm birth is another common complication with multifetal gestations. The duration of gestation shortens with increasing fetal number. In twins, prematurity is sixfold greater than in singletons, while in triplets, the risk is tenfold greater. Twins have been considered to be cognitively delayed compared with singletons. The risk for cerebral palsy is also higher among twins and higher order multiples, with the cerebral palsy rate reported to be 2.3 per 1,000 in singletons, 12.6 per 1,000 in twins, and 44.8 per 1,000 in triplets. Increased risk of fetal growth restriction, congenital anomalies, twin-twin transfusion syndrome, and fetal demise of a co-twin are some suggested contributing factors to these differences. There are also several complications unique to multifetal pregnancies, and they include the following. We will be going through each complication briefly. 1 in 20 monochorionic twins are monoamnionic. There is a high mortality rate for monoamniotic twins, and this is attributable to preterm birth, congenital anomalies, twin-twin transfusion syndrome, or cord entanglement. One subset of monoamnionic twins are mirror image twins that result from embryonic splitting that occurs on day 9 post-fertilization. These twins are genetically identical but have mirror image features such as handedness and hair whorls. Aberrations in monozygotic twinning results in fetal malformation. Outcomes in aberrant twinning mechanisms can result in conjoined twins who have shared or joined body parts. External parasitic twins is a grossly defective fetus or merely fetal parts attached externally to a normal twin. The parasitic twin consists of supernumerary limbs or often some viscera. For fetus in fetu, one embryo is enfolded within its twin. Monozygotic twinning results in two amniotic sacs and a common surrounding chorion. This leads to anatomical sharing of the two fetal circulations through anastomosis of placental arteries and veins. All monochorionic placentas are thus likely to share some anastomotic connections. Among the different vascular anastomosis, artery-to-artery anastomosis are the most common and are identified on the chorionic surface of the placenta in up to 75% of monochorionic twin placentas. Vein-to-vein and artery-to-vein communications are each found in approximately half of monochorionic twin placentas. One vessel may also have several connections, sometimes to both arteries and veins. Vascular anastomosis may be dangerous to either twin. If there is significant pressure or flow gradients, a shunt will develop between fetuses. Chronic feto-fetal transfusion may then result in the following clinical syndromes: your twin-twin transfusion syndrome, twin anemia polycythemia sequence or TAPS, and your cardiac twinning or twin reverse arterial perfusion sequence. Other complications of vascular anastomosis include your cerebral palsy, microcephaly, porencephaly, multicystic encephalomalacia, and ischemic necrosis leading to cavitary brain lesions. In twin-twin transfusion, blood is transfused from a donor twin to its recipient sibling. Prevalence of this syndrome is approximately 1 to 3 cases per 10,000 births. In this syndrome, the donor twin may eventually become anemic and develop growth restriction. The recipient twin becomes polycythemic and may develop circulatory overload that then manifests as fetal hydrops. Twin-twin transfusion syndrome typically presents in mid-pregnancy when the donor fetus becomes oliguric from decreased renal perfusion. In stage 1, there is discordant amniotic fluid volumes with the donor fetus developing oligohydramnios and the recipient developing severe hydramnios. Urine is still visible within the bladder of the donor. Stage 2 fulfills the same criteria as stage 1, but the fetal bladder is no longer visible in the donor twin. In stage 3, fetal Doppler studies become abnormal. In stage 4, hydrops develops, and in stage 5, there is fetal demise of either or both twins. Twin anemia polycythemia sequence or TAPS is a form of feto-fetal transfusion characterized by hemoglobin differences between donor and recipient twins. Unlike in twin-twin transfusion syndrome, there is a lack of discrepancies of amniotic fluid volumes. This condition is diagnosed by measuring the middle cerebral artery peak systolic velocity, which is usually greater than 1.5 multiples of the median in the donor and less than 1 multiples of median in the recipient twin. A cardiac twinning is theoretically caused by large artery-to-arteries placental shunt accompanied by a vein-to-vein shunt. Arterial perfusion pressure of the donor twin exceeds pressure in the recipient twin, and the recipient receives reversed blood flow of the oxygenated arterial blood. The recipient twin thus lacks a heart and other structures due to disrupted growth and development. The donor twin is normally formed, but because it supports its own circulation as well as pumping blood to the cardiac twin, the donor may develop cardiomegaly and heart failure. Discordant growth develops in around 15% of twin gestations. This condition is associated with increased rates of perinatal mortality. Twin discordancy is diagnosed if the abdominal circumference measurements differ more than 20 millimeters or if the estimated fetal weight difference is 20% or more. A weight discordance of more than 25 to 30% most accurately predicts an adverse perinatal outcome. The greater the discordancy, the higher the risk for neonatal complications, and these include the respiratory distress syndrome, interventricular hemorrhage, seizures, periventricular leukomalacia, sepsis, and necrotizing enterocolitis. If discordancy is more than 30%, the risk of fetal death increases to 5.6%. If it is greater than 40%, the risk of fetal demise increases to 18.9%. For the management of discordant twins, serial sonography to monitor growth is recommended. This is done every 2 to 4 weeks for monochorionic twins and every 2 to 6 weeks for dichorionic twins. Fetal surveillance is indicated, and Doppler studies of the umbilical artery can guide management. Type 1 of selective fetal growth restriction shows a positive end diastolic flow, a smaller degree of weight discordance, and has a typically benign clinical course. Type 2 shows persistently absent end diastolic flow in the smaller twin and carries a higher risk of deterioration and demise. Type 3 is intermittently absent or reversed diastolic flow and has a lower risk of deterioration than type 2. One or more fetuses may die at any time during multifetal pregnancy. When death of one fetus occurs in early pregnancy, it may manifest as a vanishing twin. In more advanced gestation, fetal death may be undetected until delivery, and in this case, delivery of a normal newborn may be followed by a dead fetus that is compressed, or fetus compressus, or a flattened fetus known as fetus papiraceus. The neurologic prognosis for surviving twins depends on chorionicity. There is an 18% rate of neurologic abnormality in monochorionic placentation and only 1% risk in dichorionic placentation. If the demise occurs after 34 weeks, however, the rate of having neurologic deficits is the same for both monochorionic and dichorionic twin pregnancies. Fetal demise of one twin occurring in the first trimester requires no additional surveillance. If demise occurs mid-trimester, the goal is to prolong the pregnancy. Elective delivery timing is debatable. Dichorionic twins can be safely delivered at term, while monochorionic gestations are often delivered between 34 to 37 weeks. Single fetal demise at term is usually delivered instead of managed expectantly. Women with multiple gestations require specialized care. During prenatal visits, it should be ensured that the maternal diet provides additional requirements for adequate nutrition and weight gain. Serial assessment of fetal growth should be performed, and signs of preterm labor should be monitored. The delivery of twins is recommended at 3 to 8 weeks for uncomplicated dichorionic gestations, at 34 to 37 weeks and 6 days for uncomplicated monochorionic diamniotic twins, and at 32 to 34 weeks for monoamniotic twins. Monoamniotic twins are commonly delivered via elective cesarean section after an administration of a course of corticosteroids, and hospitalization may also be done at an earlier age of gestation in order to perform daily fetal assessment. Mode of delivery for twins depends upon age of gestation, fetal presentation, the estimated fetal weights, and the experience and skill of the obstetrician attending to the case. Usually, a trial of labor is appropriate when both twins present in the vertex position. For vertex, non-vertex presentations, mode of delivery is individualized, while for a non-vertex presenting twin, cesarean delivery is indicated.